10 minutes because its efficacy is proved to be as much as that of the conventional C3R. And the limited evidence regarding the long-term outcomes of accelerated C3R is another drawback. The maximum follow-up which has been done till now is only up to 10 years. And in accelerated C3R, once the time comes down, the oxygen gets depleted faster. So that's why it leads to the efficacy is not as comparable as that of the conventional C3R. So there comes the role of pulsing approach, wherein we are giving time for the oxygen to replenish in between. So it's a 1 second on and 1 second off protocol as compared to the continuous UV radiation. So the only drawback in this approach is that we are not giving, the studies have not given the exact duration for which the pulsing has to be continued to get a reasonable outcome in the C3R. Next comes C3R in thinner corneas. Dresden devices standard protocol for corneas more than 400 microns thickness. So beyond that, that is beneath 400 microns, there are various modifications which have been used, including the Hafizi's hypotonic riboflavin. However, the drawback with hypotonic riboflavin is that the swelling effect is variable with different corneas with different thickness. So the effect of C3R is accordingly variable. And there comes the epithelial on approach, that is a transepithelial approach using permeability enhancers. Here again, the actual CXL effect is questionable, even though the patient comfort is enhanced and the risk of infectious keratitis is low. And the other modifications are iontophoresis assisted C3R, lenticule assisted C3R, and contact lens assisted C3R. All of these are transepithelial and better tolerated. The only problem is long-term studies are not available. And epithelial island cross-linking is a modification which was given by Masota. It's basically a partial epi-on and an epi-off approach, wherein epithelial cells are left on the top of that is on the thinnest part of the cornea. And the most frequently used and universally accepted one is a sub 400 protocol, which is given by Hafizi, which can be used successfully in corneas as thin as 214 microns. So this is a nomogram which was given by Hafizi, wherein according to the thickness we can titrate the time for which UV radiation has to be done. A similar protocol was given by Masota, but the only difference from that of the Hafizi is that it requires multiple sophisticated technologies, including iontophoresis, depending upon the thickness of the cornea. That's why it's not practically that accepted. So next one is the next UVA calculator, which was given by Shetty et al. The calculation is based more or less similar to that of given by Hafizi. Here you just have to put in the minimum corneal thickness and you will get the time for which UV radiation has to be done. Next is CXL plus procedures, wherein we combine C3R along with refractive surgeries. Whether it should be done two-stage or single stage. Single stage is preferred because second step PRK removes a part of the cross-linked tissue as well, and the risk of haze is higher, and refractive results are also unpredictable. So we have various protocols in CXL plus procedures, like PRK can be combined with C3R, which is the Athens protocol, which was studied by Kimonis, and the results have been sustained for a period of 3 years. Similarly, Critten's protocol, various studies have been done, like Shetty et al.'s TREC and TGPRK. The tissue removed in TGPRK is maximum can be removed up to 50 microns, while in TREC up to 25 microns. And you can also compare intracorneal ring segments with C3R. The only thing is that C3R should be delayed. Extra procedures are the ones which are followed in LASIK, SMILE and PRK. After the procedure, C3R can be done. The total energy delivered is 2.7 joules per centimeter square. That is 90 seconds of soaking and 90 seconds of UV radiation. Now, this is the era of customized C3R, wherein you are just using a method to improve the corneal irregularities. At the same time, you can also enhance the visual acuity. So, the PACE, which is given by Hafizi, is the latest customized C3R, which is PTK-assisted customized epithelium on C3R, wherein there are 3 requisites. One is epithelial map-driven PTK and a gradient of riboflavin concentration, which is peaking on the cone, and area of the cone receives higher total fluence compared to the rest of the cone. And it has been shown to regularize up to 12 diopters and improves the corrected distance visual acuity, and later on a touch-up PRK can be done and is used in stable keratoconus. And complications, as we all know, C3R comes with its complications, which is associated with UV, epithelial debridement and corneal flattening, which can be corneal haze and opacification, infectious keratitis, persistent epithelial defects, stromal melts, hyperopic shift, endothelial damage and associated decompensation. C3R failure, it is termed as 1 diopter or more steepening of Kmax or an increase of 1 diopter or more in the manifest cylinder over the past 6 months. Risk factors include Kmax more than 58 diopters, patient 35 years or older, female patients with weak AC, corneal thickness less than 400 microns, and those with eccentric cones. So this is the future directions which are under study, which include stem cell therapies, advanced cross-linking techniques with a better safety profile, tissue engineering, nanotechnology applications, and even personalized medicine approaches are also underway for better treatment in future. So yeah, thank you.
Thank you for that.